Hi guys, welcome to Med Crash Course. So we're doing our finals crash course today on geriatric medicine and palliative care as well. So we've got Dr. Ollie Maynard here and Dr. Nitish Sharma as well, who will be going through the sessions. We've got our Instagram QR code in the top right corner, and we've got our email at the bottom as well if anyone wants to email us. And we are recruiting people for next year. So if you are interested in teaching, especially if you're final years and want to start getting involved in the finals series, do email us and we can always sort something out for you guys. And just a disclaimer, obviously we use loads of resources out there, and we may not always reference it, but all this knowledge is from things like the NICE guidelines, Oxford Handbook and things like that, and it's not medical advice, it is just for educational purposes. Cool. So I'm just going to quickly put the link for the polls for Ollie in the chat, and if Ollie, if you can go to the next slide. Cool, if you introduce yourself and then I'll go through the polls in a minute.
Okay. Hi everyone, my name is Ollie. I'm a first year doctor working in Northwest London. I graduated from Manchester last year, and yeah, I'll be taking you through palliative care as much as I know in the next hour, and I hope it's useful. I hope I've set it at the right sort of level. We'll be focusing mostly on single best answer questions, and then I'll put my email at the end if you have any questions. So hi again, everyone. So these are the things that I'll try and be covering in the next hour. So just a quick overview on the principles of palliative medicine, which hopefully you guys should be pretty familiar with anyway. And then the bulk of the presentation, I'll go through 15 single best answer questions, give you time to answer them, and then try and give an explanation of the answer. So I've come up with these questions myself, obviously using lots of different resources. So it's just sort of the answers that I think are correct. I've tried to corroborate that with lots of evidence, but let me know at the end if you feel like any of them kind of need some attention. And then right at the very end, some of you might have already done your PSA already, but for the ones who haven't, I've got some top tips for the PSA, just because palliative medicine has a lot of prescribing in it, and a lot of it's relevant to the PSA. Just before we start, I'll let you know that I've got COVID, so I apologise if at any point I need to have a drink or cough or anything, so I apologise in advance of that. And I hope I've set the questions at the right sort of level. I've tried to think back about what I needed for finals and what I sort of needed to know. So I hope they're not too easy and I hope they're not too hard. But that being said, so palliative care is always good to start off with a definition. And the World Health Organization describes it in quite a long way, but I'll just quickly go through it. So an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering, the early identification of treatment and pain and other problems, physical, psychosocial and spiritual. So I think there's sort of three main things to pick out from there. The first one being improves quality of life. So obviously palliative medicine, there's quite a change from curative treatment to treatment of symptoms, and often that improves the quality of life rather than the quantity. The second point is patients and their families. So there's a really big stress in palliative care about treating the patient and their families as a whole, because often they'll be going through the same sort of things together, and often to treat the patient, you also have to treat their family. And then the final one is the idea of the physical, psychosocial and spiritual aspect. So it's a very holistic area of medicine. We have to think about the patient as a whole. And you're not just focusing on physical disease. And you find that in practice that a lot of the time you'll be spent talking to the next of kin, talking about their religion, what sort of chaplain they need at the end of life and stuff like that. So I thought it was important to define it that palliative care does not equal terminal care. So often it's used clinically to mean the patient is in their very last few hours or days of life. However, patients under the palliative care team can be under them for days, months, weeks, or even into years. It doesn't necessarily mean they're actively dying. So palliative care includes terminal care when they're actively dying or deteriorating, but it's also a branch of medicine where they're treated way before that, and also treating family members after the patient has passed away. So the main principles are focusing on quality of life, like I spoke about previously, that whole person holistic approach. It encompasses what's important to the patient, which is quite unique for a specialty of medicine, whereby it's normally the healthcare professional which sort of dictates what's the most important thing to treat, whereas it's very patient-led. So you have to have a really good patient-doctor relationship, and also obviously respect their autonomy and choice, because there'll be a lot of the decisions that will be made were down to the patient's choice. And obviously it's a place where you have to have expert communication, have some very challenging conversations, but also some very gratifying conversations with patients. So there are 4 main pillars of palliative prescribing. Often this is called anticipatory medications, because they're prescribed prior to when the patient actually needs them, with the idea that they may need them at some point. And normally a medication is prescribed for one of the 4 following. So one for pain, one for respiratory secretions, one for nausea and vomiting, and one for agitation. So these are the major 4 pillars of palliative prescribing. But as we'll soon find out in the rest of the talk, there are lots of other symptoms that palliative care physicians have to treat. It's not solely these 4, but these are the main 4 problems that they come across. So we'll move on to some of the questions. That was just a brief overview of palliative care. So I guess I will open the poll and speak them aloud and give you some time to answer, and then go through the answer afterwards. So let's open the poll for the first question. Hopefully that should have worked.
Yep.
So you're working on a general medical ward and looking after a 79-year-old female with advanced small cell lung cancer with brain and spinal column metastases. She has a background of depression, type 2 diabetes, ischemic heart disease, and suffering from episodes of nausea and vomiting. Which is the most appropriate treatment to start regulating? Haloperidol 1 mg, cyclizine 50 mg TDS, levothyroxine 6 mg OD, metoclopramide 10 mg TDS, or domperidone 10 mg TDS. I'll kind of wait until you guys stop voting or stop changing your votes, and when it's sort of settled, then I'll close the poll and give you the answer. Okay, so it seems like we're sort of set on the positions now, so I'll stop that there. It seems like the majority went for D-metoclopramide, and if I show the correct result, so B, cyclizine, and I'll go on to describe why. First of all, I'll just go through sort of vomiting and nausea and vomiting in general. So the vomiting center, or the emesis center, is found in the medulla of the brain, and it gets inputs from multiple different sources. One of the main ones being the chemoreceptor trigger zone, which can also be found in the medulla, which gains sort of stimulation from multiple different sources, electrolyte abnormalities, and certain medications. Other inputs to the vomiting center include peripheral pathways. So this might be from the gastrointestinal system through the vagus nerve, also through the vestibular system, through the vestibular nuclei, which then eventually feeds into the vomiting center. And then you also have those higher cognitive processes in the cerebral cortex, stuff like anxiety, which can all lead into the vomiting center. And then if the threshold is met, it will cause a vomiting response. Lots of different transmitters are used to stimulate the vomiting center, which is why there's lots of different types of antiemetics and lots of different mechanisms of actions. But if the threshold is met for a patient to vomit, they'll go through these physiological changes in turn. So there has to be increase in the pyloric tone to stop anterograde flow of stomach contents, and reduction in the tone of the lower esophageal sphincter. The glottis and vocal cords have to close to try and stop aspiration into the lungs, but we obviously know this isn't always perfect. The soft palate rises to try and stop reflux into the nasopharynx, but again, we know this isn't always perfect. And then eventually the abdominal wall and the diaphragm contract to expel the contents from the stomach up and out of the mouth. So these are the main classifications of antiemetics. As you can see, most of them target a specific neurotransmitter. So anticholinergics such as cyclizine is one of the examples, affects the, it's not anticholinergic, my mistake, like hyoscine affects ACTH receptors in the vestibular nuclei. Antihistamines, that's the cyclizine, affects H1 receptors, which thereby affect, again, acetylcholine receptors in the vestibular nuclei. Dopaminergic, such as haloperidol, levopromazine, quite a few in this class, prochlorperazine, affects dopamine directly in the chemoreceptor trigger zone. Neurokinin receptor antagonists, which aren't very common, they're not really used much in clinical scenarios, but they affect substance P. Prokinetics, which is like metoclopramide, mostly affect the gut and increase gut motility, increase gut motility, decrease gut transit time. Serotonin blockers like ondansetron have both action in the GI tract, because most of our serotonin is actually in our GI tract, but also on the central nervous system. And then tetrahydrocannabinoids, THC, is quite a niche antiemetic, but they're being used more commonly now in sort of oils and stuff. So each different antiemetic will be used for a different indication. So as we can see on the left-hand side, it entirely depends on the cause of the nausea and vomiting. In this instance, the patient had metastatic cancer with cranial metastases. So as we can see, cranial metastases are most likely going to be their cause of nausea and vomiting. So cyclizine would be our first line choice of antiemetic in this circumstance. Dexamethasone is often commonly used as well as an antiemetic, but also actually to reduce the swelling surrounding the metastases. But other indications for nausea and vomiting, say such as like delayed gastric emptying, the first line choice would be metoclopramide to try and increase that. So to try and identify which antiemetic you need to use, you need to first try and identify what would be the reason for them to being sick. And often these are overlapping. Often you can have drugs and opioid and palliative care, as well as some anxiety and pain. But in this circumstance, I believe that cyclizine would be the first line choice. So just in general, in terms of treating nausea and vomiting, you have those pharmaceuticals that we've talked about, but there's also lots of other things which can help nausea and vomiting. It's a very multifaceted symptom. So you can have reflux, which can cause nausea, which you can treat with PPIs. People are very dehydrated, can get very nauseous. People in a lot of pain, so once you actually control their pain, their nausea goes down as well. People can also have anxiety attacks or be very anxious or stressed, and actually controlling that would actually control the nausea better than any antiemetic. And then there's some more traditional treatments such as ginger and peppermint, which help settle the stomach, and other things like aromatherapy, massage, especially temporal massage and acupuncture, all which have shown benefit in nausea and vomiting. So remember, there is lots of therapies outside just simply the standard medication. Brilliant. So we move on to question 2. So I'll open the poll for question 2. So you're working in a hospice and looking after a 56-year-old male with glioblastoma. He's at the hospice for terminal care. His GCS is 12 out of 15. He is mostly confused with moments of lucidity. In his advanced care plan, he states he wishes to remain alert for as long as possible. On examination, you note he has audible, noisy breathing and crackles on auscultation. Which is the least appropriate drug to start in this circumstance? I won't go through and read them all. So it seems like most people have voted there. So I'll stop the poll and show the correct answer. So I put down there hyoscine hydrobromide, 400 micrograms subcut, and I'll go on to explain why. So the mainstay of treating breathlessness and respiratory secretions, which is what this patient is suffering from, is anticholinergic medication. So I'll quickly just remind us on the mechanism of action of anticholinergics. So these three at the top are sympathetic nervous systems, and this one at the bottom is parasympathetic. So both the sympathetic nervous system and parasympathetic nervous system uses acetylcholine as the preganglionic neurotransmitter. However, post-ganglionic, the sympathetic nervous system tends to use adrenergic neuroreceptors like noradrenaline and adrenaline, whereas the parasympathetic post-ganglionic neurotransmitter of choice is the acetylcholine again. So anticholinergics actually act on the acetylcholine receptors on postganglionic neurons, so they mostly affect the parasympathetic nervous system and block transmission of that neural impulse. So when I see the word anticholinergic, I think of anti-parasympathetic, or simply the other way around, thinking of that as sympathetic. So obviously, if sympathetic is fight or flight response, then parasympathetic is the rest and digest. So that increases secretions from our salivary glands, which obviously if we block, then that's going to cause drying up of our respiratory secretions. So that's the main mechanism of action. But you also can think of other anticholinergic medications, such as atropine, which increases the heart rate, because obviously it will be that fight or flight response and causes dilatation of the pupils to try and get as much light in as possible. Tiotropium bromide causes bronchodilation, because obviously in the fight or flight response, we want as much oxygen coming in. And oxybutynin is a medication which stops the contraction of the blood and muscle wall, because obviously if we're being attacked by a lion or whatever in the wild, then we don't want to be urinating. It's not a very safe time to urinate. So yeah, so anticholinergic, think anti-parasympathetic. So the then question goes into which anticholinergic we use. So glycopyrronium, hyoscine butabromide, and hyoscine hydrobromide are the mainstays of treating respiratory secretions in palliative care. All of them can be used. All of them are very efficable, have very good, work very well. However, as you'll see here, that hyoscine hydrobromide, we've started to reveal the answer, can cause sedation and confusion. So the reason for this, as you'll see in the first bullet point, is that hyoscine hydrobromide of the three is the only one which crosses the blood-brain barrier and actually acts centrally, especially so in elderly people. So this can have positive desirable effects. So it can cause the patient to be more drowsy. Obviously, hyoscine is used as an antiemetic if you kind of use quells, which are the kind of generic over-the-counter anti-sickness tablets. That's hyoscine hydrobromide. However, in certain patients, like the patients we're talking about here, whose desire was to remain as alert for as long as possible, this would be an undesirable side effect of the medication. One that butabromide and glycopyrronium don't actually have because they don't cross the blood-brain barrier. So this is from a patient leaflet on the side effects of hyoscine hydrobromide. And the way that I remember it is the H in hydrobromide is the H for head. So it crosses the blood-brain barrier. And this is a real example of why palliative medicine is very patient-focused, and you have to treat your patient as an individual, because this patient had specifically stated that they wanted to be alert and try not to be as drowsy and not be sedated. However, other patients might find that actually they're having lots of anxiety and they actually might prefer to be a bit sedated. So your choice of anticholinergic will actually come down to the side effect profile. And that's what we find in lots of palliative care drugs, that one is not necessarily better than the other. It's very situation dependent. So in terms of overall management of secretions, I think it's important to note that when you prescribe an anticholinergic, it won't clear any respiratory secretions which are already there. It'll only stop any new secretions being generated. And the first steps are to have non-pharmaceutical treatment. So obviously prevention is better than cure. So trying to make sure that they aren't fluid overloaded, to make sure that the hydration is adequate, but not too much, to make sure they're not secreting too much. Obviously, we can use suction to try and remove some of the secretions which are already there. And patient position, so sitting them up, having their head to the side or in the lateral position to help drainage of respiratory secretions. Obviously, if these 3 things or 4 things fail, we can move on to pharmaceutical treatments. This is actually from the Scottish Palliative Care Guidelines, which puts hyoscine butyl bromide as their first line. In the trust that I work in and the many trusts that I've seen, glycopyrronium is actually the first line choice. So it's different in the UK. However, both of these are probably you would choose them before hyoscine hydrobromide, unless, of course, that patient would be adequate for the side effect profile. So next question. Hoping it's all making sense so far and it's I'm being clear. So you are caring for a 69-year-old male with adenocarcinoma of the prostate with bony metastasis in the spinal column. He currently takes 10 milligrams of oxycodone modified release orally twice daily, and he takes 2.5 milligrams immediate release for PRN breakthrough pain. You wish to convert his background analgesia to a fentanyl patch. Which patch is the most appropriate? So a fentanyl 12 patch, a fentanyl 25 patch, a fentanyl 50 patch, fentanyl 75 patch, or a fentanyl 100 patch. It's going to take some time to do the calculation on this one, so I'll leave it a bit. Okay, so we'll go through to the answer. So I went for the fentanyl 12 patch here, and I will go on to explain why. So the calculation for trying to convert analgesia to a patch obviously can be found on the BNF. So he was taking his 10 milligrams twice a daily, so he's taking 20 milligrams of his oxycodone. And we have to convert that into oral morphine to try and make the conversion. So the table on the left, that we can see that 10 milligrams of morphine per oral is equivalent to 6.6 milligrams of oxycodone. So oxycodone is about 1.5 times as strong. So he's having the equivalent of 30 milligrams of morphine sulfate daily. He wasn't using any PRNs at the moment. He had them prescribed, but so his entire opioid intake for the day was 30 milligrams of morphine, which we can see in the conversion table converts to the fentanyl 12 patch. So a 12 patch means that he'll be getting 12 micrograms of fentanyl per hour, and patches usually last for 3 days, so 72 hours. And then obviously they need to be replaced on that 3rd day. So 12 refers to obviously the 12 micrograms, but that's not over the whole 24-hour period. That's every hour for the 24 hours until the patch needs to be changed. So next question. So you're on call on the surgical rota and you're bleeped to see a patient who is day 2 post-op for an open repair of the para-umbilical hernia. He's taking paracetamol 1 gram QDS, tramadol 100 milligrams TDS, Senna 15 milligrams once nightly, Danzatron 8 milligrams TDS, Kermoxiclav 625 milligrams PO TDS, and atorvastatin 20 milligrams once nightly. The nurse states that he has spiked a temperature of 40.2 degrees and has become hypertensive with tachycardia. From the end of the bed, you can see he is sweating heavily. Given the diagnosis, what is the most appropriate initial treatment? To escalate antibiotics to tazocin, to escalate antibiotics to intravenous coamoxiclav, to observe and monitor closely, to give cyproheptadine 12 milligrams, or 15 litres oxygen via non-rebreathe mask. Okay, so it seems like most people in that one have gone for A, to escalate antibiotics to tazocin. So let me show the answer and show you my reasoning. So I've gone for cyproheptadine 12 milligrams, and I'll explain why. So I think this patient might be suffering from serotonin syndrome. So serotonin syndrome is a very rare but clinically important syndrome caused by excessive serotonergic activation. So it can be diagnosed with the triad of cognitive changes, including anything from agitation and confusion all the way to hallucinations and in some cases coma. Autonomic changes, so increases in the heart rate, blood pressure, obviously fever as well. And then neuromuscular changes, so most commonly hyperreflexia and myoclonus or clonus of the limbs. So the reason why I thought this patient might be suffering from serotonin syndrome is that he is on 2 serotonergic medications, both ondansetron and tramadol. He's on the maximum dose of both of them and is receiving TDS tramadol and I think TDS ondansetron as well. So both of which can increase the risk of serotonin syndrome. So serotonin syndrome is uncommonly caused by one serotonergic medication, but becomes much more likely if you're having 2 or more serotonergic medications, especially if they're in high dose. So serotonin syndrome is almost always iatrogenic. It's almost always caused by medications. So this particular patient was showing signs of obviously very high fever, tachycardia, and also hypertension. So obviously because he's post-op and he's got a fever, often we immediately think fever and go to infection, which obviously would be in the differential for this patient. But if he's septic, he's more likely to have hypotension. Obviously, it's you'd go to examine the patient and do an A to E, and then you might pick up signs that he has hyperreflexia or clonus, or some of the other symptoms of serotonin syndrome. So I understand why you might think that you need to escalate the antibiotics given the small amount of history that we've given you there. But in this situation, I think you might be suffering from serotonin syndrome. So the management of serotonin syndrome, most cases are mild and resolve on their own if you just take away the serotonergic medication. You give them active cooling, active rehydration. Occasionally they need benzodiazepine for sedation of those cognitive problems and neuromuscular problems. But however, in circumstances with severe serotonin syndrome, which this would be a case of because of the tachycardia, hypertension, and because of the extremely high temperature, we can give cyproheptadine, which is a histamine antagonist, but also non-specific 5-HT, so that's the serotonin receptor antagonist also. So just to caveat that by saying there's not a lot of strong evidence for its use, but it is widely used as the antidote for serotonin syndrome. And obviously, after the initial management, you might want to then give benzodiazepines and, of course, withdraw or change the serotonergic medications. Question 5. You are caring for a 71-year-old female with cancer of unknown primary with liver and lung metastases. She's currently on diamorphine subcut pump, 40 milligrams per 24 hours. The nurses believes she is showing signs of opioid toxicity. Which of the following is not a sign of opioid toxicity? Clonus, snoring, low respiratory rate, dilated pupils, or reduced GCS? Okie dokie. So most people have gone for D, which I agree with, dilated pupils. So there are lots of different signs of opioid toxicity. Early signs including lightheadedness, delirium, hallucinations, hyperalgesia. So that's acutely, painful, lots of pain. Allodonia, so that's sensing pain from things which don't normally cause pain, so sort of light touch to the skin or pillows and such causing pain. Postural hypertension and myoclonus. So this is most often described to the patient as jerking of the limbs, which isn't seizure activity. It's specifically the muscles themselves undergoing clonus. And then obviously there's those late signs, including reduced consciousness level and respiratory depression. So if we just go through them. So clonus, yes, we know that that's a common one in the limbs. Snoring, so that's a sign of reduced GCS. So if someone's not asleep, you should always be aware of snoring because they're not protecting their airway. There's those added sounds. Low respiratory rate, obviously opioids affect the respiratory center in the central nervous system and causes respiratory depression. Most commonly, it's seen with pinpoint pupils. So the opposite of dilated pupils. If you see someone with pinpoint pupils, it might be a sign that they have opioid toxicity, and obviously that late sign of reduced GCS. And most of you will know that the cure for opioid toxicity is obviously withdrawing the opioids and giving naloxone as the antidote. So question 6, you're treating a 65-year-old female in a hospice for terminal care of metastatic breast cancer with a background of angina, gout, and CKD with an eGFR of 7. She's on a subcut pump. What is the best analgesia to start her on? Okay, so it seems like most of you have gone for E, alfentanil, which I believe is the correct answer. So obviously this patient has CKD and has a very low eGFR. They have end-stage renal disease. So our choice of painkiller will be dependent on that. So there's really good guidelines you can find. Your own trust might have guidelines themselves. In our particular trust, I think any patient, I think it's over 60, automatically gets oxycodone as opposed to morphine, as it's excreted mostly by the liver, but about 70%, I believe, but 30% renal excretion. Morphine has a much higher renal excretion. And obviously we can follow the guidance down here. And for eGFRs less than 10, we can give alfentanil. So alfentanil is 0% excreted renally. So it's the best medication for patients with very poor renal function. And also it is quite useful when you have it in a continuous subcut infusion. So that's what this thing means here. That's a pump, as it's very low volume and has very little interactions with the other drugs that you put into the pump. So it's actually a very useful medication to use in palliative medicine. So there we go. So it's not renally excreted, and it's the drug of choice in a continuous subcutaneous infusion. However, it has a very, very short half-life. That's why we use it as a continuous infusion. We don't use it as PRNs. Yeah, and you can, if you want some more information about these drugs, you can obviously just follow the links that I've provided there. Question 7. Mrs. Jones takes morphine sulfate 20 milligrams QDS and tramadol 50 milligrams TDS. What dose of Oromorph is most appropriate for breakthrough pain? So I'll caveat this question by saying this is quite a odd regime to be on, sort of 2 different opioids. Or well, I suppose tramadol has some opioid activity. So this would be quite odd to see. You'd most likely increase the morphine sulfate dose before starting tramadol. However, I just wrote this because I wanted to make the calculations a bit more tricky and a bit more interesting. So it'd be interesting to see this particular combination of drugs actually on the wards, but just for a theoretical idea, how much Oromorph would they require? 2.5 to 5, 5 to 10, 10 to 15, 15 to 20, or 25 milligrams. So it looks like most people have gone for C, which is the one that I would have gone with as well. So just going through the calculation. So breakthrough pain the analgesia that we give for breakthrough pain should be 1/6 to 1/10 of the daily analgesic requirement. So she's receiving morphine 20 milligrams and she's taking that 4 times a day. So that's 80 milligrams overall. And tramadol 50 milligrams 3 times a day. So that's 150 milligrams over the 24-hour period. So then we convert morphine, the tramadol to morphine. So we use the conversion table here, which we can find on the BNF. So 10 milligrams of morphine is equivalent to 100 milligrams of tramadol. So it's 10 times as strong. So we divide by 10 to get the equivalent dose of morphine and then add them together. So she's receiving the equivalent of 95 milligrams of morphine sulfate tablet in a 24-hour period. So we can divide by 10 and divide by 6. So she should be receiving somewhere between 9.5 and 16 milligrams for her PRN doses. Obviously, it's very difficult to prescribe 9.5, so we normally round that to the nearest 5. So sort of 10 to 15 milligrams would be her PRN dose. And if a patient is using sort of more than 3 to 4 of these doses per day, you need to think about increasing their background analgesia. 1 to 2 cases of breakthrough pain a day, you would normally keep things the same, but obviously each patient's individual. Question 8. Mr. Smith is being treated palliatively for end-stage HIV. He has a background of HIV, RA, PSP, and asthma. Which of the following is the most appropriate antiemetic to prescribe as an anticipatory medication? A. Haloperidol, B. Chlorpromazine, C. Ondansetron, D. Metoclopramide, or E. Prochlorperazine? So C on danzatron. And this really comes down to the mechanisms of action of all these different antiemetics. So the patient is suffering from PSP in their background history, which is progressive supranuclear palsy. So this is a Parkinson's plus syndrome caused by tau proteins depositing in the basal ganglia, as well as other places in the brain, leading to neuronal death. And so then a reduction in those dopaminergic pathways and reduction in the level of dopaminergic neurons found specifically in the basal ganglia, which obviously will give you those extrapyramidal symptoms. It's normally quicker onset in terms of at a younger age than traditional idiopathic Parkinson's disease, and it has a much quicker progression, unfortunately. So the particular medications, 4 of them were dopaminergic medications, which block dopamine at the D2 receptors, which is excellent for the antiemetic effect, but unfortunately would have the side effect of potentially increasing the extrapyramidal symptoms that he sees from his Parkinson's plus syndrome. So this is from the Parkinson's website and is not an exhaustive list, but some of the medications to avoid in Parkinson's-like syndromes, including chlorpromazine, haloperidol, metoclopramide, and prochlorperazine. So danzatron in that list was the only one which didn't act on dopamine receptors. So you were caring for an 81-year-old male in the terminal phase of his life due to decompensated liver failure. In his advanced care plan, it states he does not want any intervention that would prolong his suffering. His preferred place of death is in a hospice and does not want to be admitted to hospital. He experiences a catastrophic variceal bleed and hematemesis. What is the most appropriate intervention in this case? So it seems like most of you have gone for either A, B, or C there. And of the 3, I would have gone for midazolam 10 milligrams sublingually. So just a quick discussion on terminal agitation. So obviously agitation is one of the 4 main things you're trying to prescribe for in palliative care. So terminal agitation is the agitation which occurs in the last few days of life. It's very common. Greater than 50% of patients will suffer from terminal agitation. It can have lots of presentations, including sort of anxiety to restlessness to hallucinations to sort of hypoactive delirium, and lots of causes as well. So like I said, there's lots of different signs that you need to keep an eye on. Most of them it's intuitive from just looking at the patient to see if they're suffering from agitation. But there's some which you might not know that they're actually suffering from agitation. So it's important to observe the patient closely, obviously go and see them regularly. And the nurses will also check out for agitation. So when someone is being palliated in the terminal phase of their life, they tend to stop routine observations and start palliative observations, which include checking for signs of agitation, pain, respiratory secretions and such. And it can be caused by a whole host of issues. Obviously, these can be overlapping and be multifactorial at the same time. Things that might be common in palliative care would be, tumours from cancer, altered body levels. Obviously, is going to be almost guareguaranteed when you're coming to the end of your life and your body organs are shutting down, you're going to have some amount of electrolyte abnormality, as well as organ dysfunction. So there's lots of different causes for agitation. And the mainstay of treatment for agitation is benzodiazepines. So just a quick recap on how they work. So they're a class of drug which act upon GABA receptors in the central nervous system, specifically GABA A receptors. So they bind to the alpha and gamma subunit of the gamma A receptor, causing binding. Sorry, I have to get a sip of water. So activation of GABA receptors causes the inhibition of the firing of the action potential. So they're actually an inhibitory neurotransmitter. And so it sort of dampens down the action within the brain. So just as a quick comparison between the major benzodiazepines we use. So lorazepam is a very common one, which would be described as short-acting. Diazepam is a more common one, which would be described as more intermediate to long-acting, and is more given for chronic anxiety due to its sort of how long it takes to onset and how long it's in the system for, so it can stay in there for 20 to 100 hours. And midazolam is the benzodiazepine which is very commonly used in palliative care, mostly because it is got a very short onset of action, but it's also processed quite quickly. And again, it can be used in subcut pumps and doesn't really have any problems with being mixed with other medications. So midazolam is often the drug of choice. So this is quite a useful table, just comparing them all. So we see midazolam at the bottom here. The action of onset is 0 to 15 minutes when you have it orally. So in this particular patient, which was having a very catastrophic variceal bleed, who doesn't want to go back into hospital, who doesn't want any life prolonging treatment which may cause suffering. So giving him packed red cells, I think, would be inappropriate. Mostly because you're not actually in a hospital setting. He said he doesn't want to be admitted to hospital. So similarly, giving him intravenous fluids is probably not appropriate. So lorazepam was one of the options, but it was IV, so he'd need a cannula. It's uncommon for patients in hospice to have a cannula. Some hospices, they do have them. It's even more uncommon to have patients in the community with a cannula. So an oral preparation may be best. So if and it's dissolved very quickly under the tongue, so even if he's still vomiting, they should hopefully still be able to dissolve and get into the system, and it acts very, very quickly. So midazolam would be the benzodiazepine of choice there. So question 10, which of the following pharmaceuticals is not commonly used in the treatment of intractable hiccups? Is it A, metoclopramide, B, pantoprazole, C, dexamethasone, D, nifedipine, or E, morphine? So quite an uncommon symptom, hiccups, that you have to treat in hospital, but it does happen. And morphine is not commonly used to treat hiccups. So there's lots of different causes of hiccups, including gastric stasis, which is why metoclopramide might be useful, gastric reflux, which is why a PPI might be useful. Stuff like infections, irritation of the diaphragm, and hepatic disease, and also cerebral causes. So lots of different causes. So like with any symptom, it's important to identify the underlying cause before trying to treat, because obviously it will depend on what treatment we give them. So there's non-pharmacological treatments. So stuff like sipping ice water, swallowing crushed ice, breathing into a paper bag, interrupting normal breathing by holding the breath. So all these things that you might try, yourself at home if you're trying to get rid of hiccups. But often if it can't be treated using non-pharmacological treatments, we have to give one of the ones on the previous slide. However, we don't often give low-dose morphine, but there is some indications for low-dose morphine in palliative care, hiccups not being one of them. But we can have a cough or shortness of breath in palliative care. So the 1 milligram is unlikely to have any analgesic effect, but it has been shown that the low doses of morphine still have an effect on the respiratory center in the brain. So if anyone suffering from shortness of breath, which is causing them some distress, you can kind of sort of try and slow their respiratory rate and reduce their distress by giving them a trial of some very low dose morphine. Similar for the cough reflex, that's dampened down by the low morphine as well. So that would be the indication for low dose morphine. Question 11, you're looking after a 75-year-old male being treated for a community-acquired pneumonia with his condition has progressively worsened overnight and the decision was made to switch to a palliative approach. He passed away in the morning. You confirmed his death on the ward. He has a past medical history of ischemic heart disease, hypertension, mesothelioma, type 2 diabetes, and benign prostate hypertrophy. Which of the following will be put as 1A on the patient's death certificate? So A, community-acquired pneumonia, B, type 2 diabetes, C, BPH, D, mesothelioma, or E, hypertension. So all of you going for the right answer there. So community-acquired pneumonia. So I've actually lifted this directly from the Antiemetics website. So they have a couple more examples that you can go through and pick which you think is the right answer. So death certificates, 1A is the disease or condition which directly led to their death, which in this case would be the CAP. And then you go down from that, from 1B to 1C, through other diseases that led to the eventual cause of their death. So 1B in this case would be mesothelioma, which most likely led them to be susceptible to the community-acquired pneumonia. And then part 2 is for any condition that may have had an impact in their death, but not necessarily directly caused it. So this doesn't mean that in this section you just list every single one of their past medical histories. So BPH wouldn't have been relevant in this situation, so that doesn't have to get listed. So as we can see here, 1A, community-acquired pneumonia, 1B, mesothelioma, and other contributing factors like ischemic heart disease or type 2 diabetes. So you will most likely have to fill out death certificates as a junior doctor. They can be quite complicated. So there's normally always a bereavement office or a bereavement team in the trust or hospital you're working in, and they're normally really helpful. They are brilliant at going through the patient with you and trying to figure out the death certificate. So feel free to contact them if you struggle. So question 12, what framework can be used for breaking bad news? Is it A, the ICE framework, B, the SOAP, C, HARK, D, CAGE, or E, spikes? So yeah, quite an easy one here. I think most people know it's spikes. Most of us have heard of it before and used it before. So just to cover what the other ones are. So ICE, obviously ideas, concerns and expectations, normally used in sort of history taking. SOAP is a framework which people use for writing in the notes. So if you're being asked to write in notes on the ward or as an F1, you can use the SOAP mnemonic. HARK is used to screen for abuse. CAGE obviously used to screen for alcohol, and then obviously spikes used as a framework for breaking bad news. So just to quickly go through it, so setting is really important, so making sure that you have privacy, that you're not breaking bad news in a bay or you know, where other patients could hear. Trying to first understand what the patient or relatives already understand about the disease or the situation, because there's no point going into the complications of a perforated appendix if they didn't even understand why they were in hospital. An invitation, so sort of understanding where they're at and obviously making sure they're on the same page and asking them if you're happy to share with them the information, and then obviously eventually giving them the information that you'd like to give. But obviously it's about being patient and not obviously dropping that on them straight away. It's about giving them warning shots and eventually working in and you think they will fully understand. Obviously showing empathy throughout. This doesn't have to be done in this particular order. Obviously making sure that you're on the patient's side and understand where they're coming from, and then summarizing and strategizing at the end, trying to come up with a plan. So what's important to understand is that for really bad news, often cancer diagnoses, patients won't hear anything after you say cancer. So it's important to give them phone numbers and places to go and to seek information, because they won't take anything in. That's been well documented afterwards. They won't necessarily take anything in. So question 13, which of the following statements regarding DNA CPR decisions, so that's do not attempt cardiopulmonary resuscitation, is false? So which of the following is not true? So A, a DNA CPR form is a legally binding document. B, a patient does not have the right to refuse a DNA CPR decision. C, attempts to communicate the DNA CPR decision to the patient and or next of kin must be made unless doctors think that doing so would cause the patient harm. D, DNA CPR forms can be temporary. Or E, learning disabilities, autism or dementia are not reasons to be put on the DNA CPR form. So which one is not true? Okay, so most of you going for the correct answer there. So A. Oh, don't know why I pressed that anyway. So DNA CPR form is not a legally binding document, whereas all the rest of the statements are true. So a DNA CPR decision is simply a tool to help tell doctors and nurses not to attempt CPR. If a patient wants a legal document to say that they do not want resuscitation, they have to make an advanced decision. And then obviously if you're breaking that advanced decision, then you are actually breaking the law at that point. Whereas the standard DNA CPR forms that the patient does not sign, that is just put in place by whoever the healthcare team to try and stop any inappropriate resuscitation attempts. In regards to the other statements, all of which are true, the decision to resuscitate is a decision made by the medical team and should be in conversation with the patient and the next of kin. However, the patient cannot demand to be resuscitated. So they do not have the right to say, you must try and resuscitate me. That's a decision which is made by the doctor, and no doctor has to give a patient a treatment if they don't think it will work. If it's futile, then it's not something we have to do. However, if you do put a DNA CPR in place, like we said, it should be tried to be communicated with the patient, and it should be documented, obviously, by the most senior doctor in charge of the patient's care that's at work at that time. And they can be temporary, so the DNA CPR decisions, they can be revoked if the patient's situation changes or their decision changes. And often the ones they have in hospitals are temporary, and if they go home, they won't continue with them into the community. So there's a really good website. It's just the NHS website, but it has explanations of all these things, which is where I got all this information from. So it's quite a good resource. Question 14. Which of the following is not a typical part of the death confirmation exam? So when you're confirming death, which bit is not typical? So A, auscultating for heart and breath sounds for 2 minutes. B, checking for a central pulse, C, an ECG, D, checking pupillary response, and E, checking the patient's response to painful stimuli. Yep, so all of you got it. So it's the ECG. So it's not commonplace when you're doing a confirmation of death exam. So these are the usual steps. So when I confirm death, I would take the approach as I would with any patient. So I observe the patient from the end of the bed. So that's looking for spontaneous movement or spontaneous breath. And then, as if I saw a patient, you know, out on the street that I was concerned about, I'd then go and check for a verbal response, ask them to open their eyes for me. And then obviously, if I can't get a verbal response, I'll then check for a pain response. And then eventually feel for a central heartbeat. And obviously, in any other situation, that's when you would commence CPR. But obviously, this being a patient who's got a DNA CPR in place or is an expected death, you won't do that at that point. So that's when you can go on and check the heart sounds and checking the eyes for response. So it's just a systematic approach, just to make sure you cover all areas. So there's no specific amount of time that you're supposed to listen to heart and chest sounds for. The recommendation is at least 2 minutes. Some say at least 5 minutes. I will get out my phone and actually get a timer on to make sure I do the 2 minutes, because it can feel like a long time when you're listening to nothing. It feels like a very long time and you're not quite sure how much has passed, especially when it's in the middle of a night shift and you've just woken up. So obviously making sure that if the patient's next of kin's there with you, explaining what you're doing as you go along. And obviously if you're getting your phone out, it's important just to explain that you're just timing it and that you have to remain quiet. We can use an ECG if you're unsure. Often when you're listening for the heart sounds, you can hear the movement of your hand or hear the stethoscope rubbing against their chest, which can put you off. So if in that situation, you can ask for an ECG and obviously be checking for asystole. So documenting, this comes from Geriatric as well, is really important. So it's important to state whether the patient had a valid DNA CPR in place. Note whether the death was expected or unexpected. That'll help you decide whether it needs to be referred to a coroner. Note each step in the exam. So you specifically write, you know, checked for verbal response, no response, checked for painful stimuli, no response, you know, listen to the heart for over 2 minutes with no sounds heard. So you want to put each individual finding that you've put down. You want to document whether the next of kin has been updated, because it can cause a lot of trouble if people come in the morning and they don't even know if the next of kin have been told. The time of death is the time that you complete the exam. So often on a busy night shift, you might be asked by one of the nurses to confirm death for one of the patients. However, other patients take priority. So it has to happen a couple of hours later, but you can't put the time which the nurse told you. You have to put the time that you actually completed the exam, and you put that to the nearest minute. So you want the exact time. And then it's good practice to put all of your contact detail to make sure that anyone can contact you if they need to. Like I said, all this information I got from Antiemetics. The cruise website is a website for bereavement. It's a good thing to have up your sleeve in OSCEs if you're having to console a next of kin or give them a bit of information of somewhere they can go. And it's also really good in real life if you have patients who are not sure what to do or how to process it. You can point them towards the cruise website. So last question, almost there. So you're a 91-year-old female in hospice. With a background of type 1 diabetes, AF, asthma, and hypothyroidism with an eGFR of 67, her medication are as below. You wish to rationalize her medication to reduce her pill burden. Which of the following medications would be most appropriate to stop? Yeah, so this is quite an easy one to end with. So I would say atorvastatin is probably the most appropriate to stop. The reason for this is that statins give you benefits over years to decades, more decades really. And any benefit that she would have gained has most likely already happened by now. And the small amount of benefit she would be gaining is probably at too high a cost for the pill burden. So if you want to understand more about statins, there's a really good video by Rohan Francis, who's a cardiologist who also is a YouTuber, and he explains statins and the benefit that people derive from them. And it's a really good video to direct your patients to as well. It gives a really clear understanding of the pros and cons of statins. So just quickly on pill burden, so that's just simply the number of tablets or capsules that you take every day, and it's the bad consequences of having to take too many, not only the side effects and the interactions, but obviously the problem with storing the pills, having to go get the pills, having to pay for them, swallowing difficulties, remembering what they're for and at what time of day to have them. Some patients can be on 10 plus pills a day. That's not that uncommon, and it can be a real cause of strife. So trying to reduce that pill burden is a positive thing to do. So the stop-start criteria are used not solely in palliative care, but in geriatric care, mostly in general. It gives a brilliant list as to reasons why you might want to stop some of their medications and reasons why you might want to start other medications. And you'll see in clinical practice that patients may be started on medications years ago that have had their benefit, but they're very good at starting medication. We're not actually very good at stopping medications. So it's a really helpful tool to use. So that's all the questions I got. I hope they weren't too difficult or too easy, and I hope that my explanations were useful. So just some of my top tips for the PSA if you haven't already done it. So for me, using the Control F function is really useful. I think probably most people know about this, but trying to skip to the certain bit of the BNF that you need by searching, specific search requests is really, really useful. I only learnt this quite late, but there's Stockley's interaction checker on Medicines Complete. So there'll be lots of questions about interactions of certain medications, which the BNF doesn't have a very good interactions checker, but the Medicines Complete has one. So I had both loaded up when I was doing my PSA. So there's the good medicines guidance section on the BNF. So that's where a lot of the information I got today was from. So the palliative care section is really useful. It has all the opioid conversion tables, which obviously there'll be questions on. And then just quick ones which scuppered me. So like 1% solution, like a cream, means 1 gram in 100 mils. Something quite simple, but obviously quite important to remember and easy to forget. And then always check units, micrograms versus milligrams. Often in the medication review, there'll be a drug which is supposed to be in micrograms, but is actually in milligrams. And then best to always consider renal function and allergies, as there'll be reasons for prescribing one drug over another. And that's true of real life as well. Obviously, very, very important to check the allergies is the first thing you do. So thanks everyone, thanks for listening. Hope it was useful. If you have any questions for me, feel free to email me. I'll try and get back to you as quick as possible. And if you'd like the slides, I'm sure there's lots of information in there that you might want to take. Feel free to fill out the feedback form and then we'll send out the slides for you.
Hello everyone, my name is Nitish Sharma. I'm one of the SHOs at Ealing Hospital, and today we'll be going through geriatrics, a few common presentations in geriatrics. Okay, so let's start with the first one. This is the most common presentation in any hospital with geriatric patients. Falls, whatever might be the case, there are a number of differentials that could come under falls, and whatever might be the case, they could present with the falls. So let's start. Okay. So as I told you, most of them present with falls. So leading cause of mortality resulting from injury in people aged above 75 years. So even today on the wards, we had a patient who had a fall, was on blood thinners, and had an intracranial bleed and probably won't survive that. So you can see how common it is and how dangerous it could be. So this is just a few epidemiology of the falls. risk factors. So most commonly, if a patient has a previous falls, they could have another fall, because even though you correct the fall, the frailty is not corrected. So this causes more and more falls. And then female gender predisposes to having falls, age, and disorders of gait and balance, like Parkinson's, or it could be a cerebellar disease, then visual impairment, cognitive impairment, uh, high level of dependency with ADLS. So this is the most common cause for mechanical falls. And then foot problems, arthritis, lower limb weakness, then stroke, definitely Parkinson's, as I told you, with disorders of gait, polypharmacy, very important reasons for one of the most common reasons for fall, alcohol. This is not common in elderly, but more in patients aged about 50 to 70. Then environmental factors, infection, using of walking aids like walking stick. This predisposes again to the mechanical falls. Okay, so if a patient presents with falls, how do you start? So first of all, history is very important with the falls, because in most cases, the history will give you the exact reason for the fall. So first of all, when it happened and how it happened. By how, you need to ask what the patient was exactly doing before the fall, and was there any loss of consciousness, injuries, pain, loss of function, headache. So with headache and the loss of consciousness, you could start thinking of a neurological cause. With alone loss of consciousness and palpitations, you could start thinking of a cardiac reason for the falls. Then you go on to examination. Temperature, very important, because sepsis is one of the most common causes of falls. And if there's a spike, temperature spike, you could start thinking of sepsis as a common reason for falls. Then bruising, a reduced function. Bruising is important to look out for any injuries. Postural hypotension, very important. So whenever a patient comes with fall, this is the first thing you should do. With the OBS, you should have a lying and standing blood pressure. Pulses, neurology, a fundus examination, very important to look for any intracranial reason or neurological reason. Vision testing, very important to rule out any mechanical reason of a fall. Then investigation. So first of all, going on with the routine ones, full blood counts, use and ease, and LFTs, TFTs, vitamin B. And yeah, very important, urine analysis to rule out UTI. UTI is very, very common in elderly, and another very common cause of ECG, as you would do with to rule out any cardiac reason. Echo, this you won't do as starting investigation, initial investigation. This would be later on in the admission. Then specialist assessment, this again would be on later on in the admission. So then you start with the treatment. So start with the emergency treatment, which or the first one would be NOF. So even when an elderly comes with a fall, rather than going to find out the reason for fall, you need to tackle the emergency, which is fracture NOF, and subdural hematoma, pneumonia, hypothermia, UTI, dehydration. These are all the reasons that could immediately lead to mortality. So you need to focus more on these rather than finding out the reason for fall initially. Okay. So how do we start with the fall assessment? As very important, history. When did it happen? How did it happen? What happened before the falls, during the fall, and after the fall? So during the fall, it is very important to ask for if there was any loss of consciousness, any abnormal movements, how long it lasted. And then after the fall, there are a few key features that you need to ask. First of all, any confusion, to rule out any neurological cause, any headache, any injury, any vomiting, and then very important, any amnesia, retrograde or anterograde in amnesia, very important. Then you would start with your examination. Start with the gait, balance, mobility, muscle weakness. Then in elderly patients, it's very important to see if there are any previous investigations any risk of osteoporosis that could predispose the patient to a fracture, especially nerve. Then you start with the so it's very important that in some elderly patients would have fall because they have a fear of fall. What does this mean? So usually the patients won't go out because they fear they could fall. This leads to muscular atrophy and loss of confidence, which leads to a fall which otherwise won't happen. So it is very important for the physiotherapy to involve physiotherapy team to tackle this fear of falling. Then visual impairment, cognitive impairment, neurological exam, very important to rule out neurological cause. Continence, another very important thing to look at is continence. If the patient had any bowel or bladder incontinence during the fall, this would again point out to some neurological cause. Then this would be later in the process of admission, the home hazards and medication review. So cardiovascular exam, very important because leading cause of fall in elderly is cardiovascular reasons. So first, so most common cardiovascular reason is arrhythmia, and most common arrhythmias are bradyarrhythmias. In bradyarrhythmias, most common are the heart blocks. So let's start with an SPA. So 80-year-old female presented to ED with a fall. The patient is a nursing home resident. History from patient and a collateral from nursing home tells that patient had 2 to 3 falls over the past few days, 7 falls, including blackouts, loss of consciousness, lasted a few seconds, no abnormal body movements, no incontinence during the falls, but the patient becomes pale and has sweating and flushing after the falls. The falls are not associated with the postural change as well. So the patient has background of, as any elderly patient, hypertension, hypercholesterolemia, and type 2 diabetes. So what is the most appropriate initial most appropriate investigation for diagnosing the most likely underlying cause? I'll open the poll now.
So guys, I have put the QR code and the link in the chat. I will repost it as well, just in case anyone's missed it.
Ash, would you mind just rechecking the QR code?
Yep, I'm just doing that. I just made a new QR code, so that should hopefully solve the problem.
Okay. Okay, so stop the poll now and show the results. So yeah, so the correct answer is Holter ECG. So the key thing is most of these answers are correct, but the key thing is that what is the most appropriate investigation for diagnosing. So yes, you would do CT head to rule out, because in any elderly who had a fall with a head injury, you would always go for CT head. And then another thing, EEG important, but not in this case, because there's, as you can see, there's no abnormal body movements, no incontinence, so highly unlikely that it could be a seizure. Holter ECG, very important, because as I told you, the most common cause in elderly for falls is cardiovascular reasons, and in cardiovascular reasons, most common is arrhythmia, and in arrhythmias, bradyarrhythmias, and in bradyarrhythmias, it's heart blocks. So Holter ECG, so one of ECG won't be very helpful. If you're if it, even if it is normal, it won't be very helpful. So Holter ECG would give you a better understanding of what's happening. So as with falls, so as I told you, it's very important for to get a good history. With loss of consciousness, it could be just a syncope, it could be seizures, it could be dizziness. Arrhythmia is very important. With loss of consciousness, patient might lose a bit of output for a few seconds, and this would cause loss of consciousness. This would lead to the, as in this case, you see there's a flushing and becoming pale, and then there's a flushing. So this is basically because of losing output few seconds and then gaining back the output. So drop attacks would be patient is suddenly walking and just suddenly drops. No warning signs, no triggers, and it could be cardiovascular, carotid sinus disease, TIAs, orthostatic hypertension. Okay, so how would you manage this? So manage the falls. So first of all, or definitely you would go for treating the reason for the falls, but as we are dealing with geriatrics, there is much more to deal with rather than just the reason. So this would include our physiotherapy team, which would, and occupational therapy team would get into strength and balance training. Home hazard assessment, as I told you, patients who are having fall, a previous fall, are more prone to have another falls. So even though we might treat the reason, there definitely is a chance they would have another fall. So home hazard assessment is very important in this case. Medication review, very important, we'll get to this in a bit. And cardiac pacing, as I told you, most common cause is bradyarrhythmias, and treatment for bradyarrhythmias would be a cardiac pacing. Visual assessment for mechanical reason of fall could be important. So as I told you, there's a recurrent chance of fall, so it's very important to educate the people how to cope with fall, and what changes are they willing to make. This basically involves encouraging them on moving out with help, going for physiotherapy, community physiotherapy, or in a rehab center. Motivation regarding fear of falling, as I told you, fear of falling causes even more falls. And a measure, explaining the measures to prevent falls, how they could use equipments to prevent falls. And some falls, like mechanical falls, could be totally preventable, and it is very important to educate the elderly people about that. Okay, going on to our second SBA. So a 92-year-old male admitted from from home with a new confusion. Poor historian, as with every elderly patient. Collateral history from the family: there is a general decline, reduced mobility, reduced oral intake, has been agitated for 2 days, and has been constipated from the past few days as well. Background of ischemic heart disease, heart failure, type 2 diabetes, hyperlipidemia. And then drug history is taking metformin, atorvastatin, bisoprolol, ramipril, aspirin, isosorbide, mononitrate, aqueous cream. And blood show raised white cells, raised CRP, and a low sodium. Urine dip is positive for leukocytes and nitrates. And so, what would be the reason for this patient's condition? Okay, I'm opening the poll. First of all, you need to identify what's the condition. Okay. Okay. I'll just start the poll. So the correct answer is all of above, because first of all, this patient is having everything under the sun. Polypharmacy, very important reason for fall for this condition. So what first we need to identify what the patient is going through. So this is most likely a delirium, and delirium, there could be multiple reasons for delirium, polypharmacy being topmost. UTI, any infection predisposes an elderly patient to delirium, hyponatremia. So another very important cause. Then constipation. Constipation is the most missed cause for delirium. Okay, let's start with what is delirium. So basically, it is disturbance of consciousness and a change in cognition, reduced ability to focus or shift attention, short period of time, acute, and a tendency to fluctuate. Very important. The last 2 points are very important. Let's go. Okay. So three main types of delirium: hyperactive, hypoactive, and mixed. So hypoactive and mixed delirium are very difficult to recognize, as with a hyperactive patient, a patient who is restless, agitated in the wards or on admission, everyone would be able to identify and flag it up. But a patient who is in the ward sleeping quietly, or who's admitted with who's just sleeping, resting in ED, everyone misses. No one's getting disturbed. Everyone misses this. It's very important to recognize hypoactive delirium as well. And the mixed delirium is difficult to recognize because of the fluctuating course. So a patient might be living alone, and sometimes the carers would come and see that the patient is completely normal, but as soon as the carers go, the patient might become agitated, or when a doctor sees them, they are normal, and then again, when a GP sees them, they're normal, and then when they go home, they become again hyperactive. So this is very important to know that delirium has a fluctuating course, and it needs to be comprehensive assessment, and not just a snapshot like in a particular period of time. Okay. So what are the causes for delirium? So environmental causes, very important. So sometimes what happens is patient is admitted to the hospital, comes to A&E, goes to acute medical ward, goes to a short stay elderly ward, goes to a long stay elderly ward, and this all happens within a few hours. This causes a lot of change of environment for the patient, from being at home to being in different wards in the hospital, and this predisposes to more delirium. And other causes could be sleep deprivation, as elderly patients don't have much of a physical exercise. They have difficulty in sleeping, which predisposes them to delirium. And immobility, hearing aids, definitely. So with the environment, if a patient is unable to assess what's going on, especially an elderly patient who's got a background of multiple medical conditions, this would have a very high risk of developing a delirium. Then we would go on to the medical causes, which would include fluid and electrolyte abnormality and neurological illnesses like strokes, seizures, subdurals. Pain is very important. So sometimes what happens is an elderly patient who's got absolutely no background of any medical condition would and it's very common to see an 85-year-old man who had a fall and injured himself going into a delirium, and then it starts all going all downhill from there. So it's very important to manage the pain, because as soon as a patient comes, we start tackling the numbers, we start treating white cells, we start treating CRP, electrolytes, but no one treats the patient actually, which means giving acute pain relief. Respiratory causes, hypoxia, very important. Hypercapnia, another very important reason for delirium. So elderly patients would have a COPD, and we would just on admission give 100% oxygen, continue that, maintaining SATs 99%. And patient would be confused, agitated, pulling the mask. We would be forcing the mask, which would be just making the conditions worse and worse and worse. The drugs. Polypharmacy, another very important cause for delirium. We'll talk about this in a bit. Infections are very important. So as I told you, even a slight infection that like a UTI could lead to delirium. Even with some outpatients, patient who don't need admission just because of a UTI would go into delirium and end up needing admission. Surgery, after surgery, it is very common to see patients have becoming delirious after the surgery. This is often missed as a post effect of anesthesia, but this is more of a delirium rather than post effect of anesthesia. Okay. Urinary and fecal retention, very important. As I told you, constipation and urinary retention are the most commonly missed causes for delirium. We would just look at the numbers or the blood test. We would examine the patient, but we would forget to take a good history regarding the bowel and urinary habits of the patient. And we need to specifically do a PER exam in elderly patient who's delirious and we can't find any other cause. So next on, how would you manage? So as with environmental causes, we would avoid any frequent bed moves, keep the patient at a particular place, avoid if the patient needs to go to a long stay elderly ward, he should go directly from A rather than going through all the different wards. Then very important to reorientate the patient. Sometimes what we would do is a patient who's being agitated, we would just put walls in and just ignore the patient completely. It is very sometimes it's I mean it's amazing how sometimes just by explaining the person where they are, we are, who they are, who the family members are, and they are able to understand everything and settle down without any medication. So sometimes we would just a patient comes to A&E and we would just insert a catheter just because we think it is a UTI and patient is retaining, but it would only lead to more delirium. Patient who's fine on admission would end up being delirious because of multiple invasive devices like catheter. So for with every procedure, even with taking blood, you need to explain in detail what you are going to do. If the patient is not able to understand, it's very important you take your time to make the patient aware what you're about to do. So pharmacological treatments. So NICE says that this should only be used to control challenging behavior where there's a risk of harm to patient or the other people around. So for short term, we would use haloperidol, but in practice, you would see that lorazepam is the most commonly used. Why? Because there are a number of contraindications for haloperidol. First one being Parkinson's. Okay, so going on next, treat the cause, you treat the delirium. So very important to treat dehydration, constipation. So it's amazing to see how many patients get better just after they start opening their bowels regularly, or they are having plenty of fluids without even any medication. We would see this very commonly in long stay elderly wards, where the people are staying in hospital like a month maybe. They are medically fit, waiting for placement somewhere, waiting for social conditions to be sorted, and they would end up being delirious. This would be because of the constipation. This would be because of the environmental causes, and just by giving a good laxatives and patients opening their bowels, they would become better. Infection, very important. This is very hard to miss. And in fact, it's very hard to miss an infection as a cause of delirium, because when we think of delirium, we think infection is the number one cause. Hypoxia, another very difficult to miss cause, as the nurses would flag you up as soon as the patient desaturates. Pain and discomfort, very important. So, as I told you, it's very important to manage the acute pain rather than just treating the numbers. So multiple medications. So as Ollie was telling, that sometimes there would be medications which are started ages ago and are not needed at the moment, would only lead to polypharmacy and causing delirium. So this leads on to our next topic, polypharmacy. What is polypharmacy? While there is no particular definition or consensus, but I mean, most studies say that it would be a threshold of 5 or more medications per day. But in practice, you will see a number of patients taking a much more number of medications than 5 per day. So, uh, appropriate polypharmacy is when the use of medications has been optimized. As I told you, the medications that have been going on for a long time, just because the patient is taking on admission doesn't mean that patient needs to take it in the hospital or on discharge. And we should use the best evidence to stop these medications, or give only the ones that are required without any. So, what do you mean by appropriate and inappropriate polypharmacy? So, you would just need to outweigh the benefits and the risks. So, what does this mean? So, there are patients who are elderly, like 90 years old, and taking uh, 3 antihypertensives, uh, a statin on a maximum dose. We should stop and think, like, what are we trying to aim with this? An elderly patient, 90 years old, has probably the statins and the antihypertensives have already worked and reduced and increased their life expectancy. And now with it's of no use giving them excessive statins, because the patient is probably not eating that much. Probably his blood pressure is being on a lower side. So we just need to outweigh the risks and benefits. And yeah, so as I told, that improving the duration and quality of life, which is important. So sometimes continuing a statin for a 92-year-old patient won't probably affect the quality of life or improve any duration of his life. Then symptom control, is it controlling any symptom, or is it just we are just continuing because it was a risk? Then prevention, and is it just we are using for prophylaxis, or is it something that we actually need? Then inappropriate pharmacy would be that the risks outweigh the potential benefits. Like, if it's just a prophylactic medication and does not solve symptom, doesn't mean that the patient needs to take it. Okay, so what would be the impact of polypharmacy? The ones we talked, pulse and delirium, most important ones. Functional impairment, cognitive impairment, urinary incontinence. So a lot of medications would cause effect on autonomic nervous system and cause urinary incontinence. Impaired nutrition. So it's very common to see people taking a lot of medication, complaining of loss of appetite. Dehydration and constipation. Another very important thing with more medications predispose patient to constipation, which predisposes to delirium, which predisposes to fall. So it's all interrelated. So risk factors. So treatment. So guideline-based prescribing. So it's very important to prescribe fully based on guidelines and not just to prescribe anything just because it lowers the risk. Then it's important to check any adverse effects related to the medication. And sometimes what happens is a healthcare provider just prescribes because the blood pressure is not being controlled. Sometimes we would just prescribe another antihypertensive just because for a short term we need to bring down the blood pressure. And what happens is this ends up continuing on discharge. For example, just a few days ago, I saw a patient whose blood pressure was 180 something, and he was given additional amlodipine just to bring down the blood pressure. His blood pressure was 110 when he was going to be discharged, but still he was given amlodipine. So it's very important to rationalize that if something has been started in the hospital just for short term, it's important to stop that when the patient is being discharged. So yeah, that's the second point, which is infrequent medication. The patient would have a medication and have not a review after that. So yeah, with elderly, what happens is basically our body there's a change in pharmacokinetics and pharmacodynamics of the medications. So basically, the elderly patient's body reacts differently to the medications, and that's why we try to prescribe lower doses of medications in elderly. And this is basically because of the general physiology of aging, and also changes how the drug acts on the body. So one thing is that with elderly people, it's difficult to clear the drug from their blood, and also the action of the drug is potentially increased or decreased, which causes further complications. So it's very important to frequently review the medications. So addressing polypharmacy. So first of all, assess the risk. Very important for any elderly patient of age above 80. It's very important that the risk of polypharmacy is very high. So it's important for to assess the patients who need a review. Then would be annual review in all older adults. So this is very important that annually all the medications are reviewed. Inform caregivers of medication changes to, oh yeah, sometimes it's just a lack of communication. What happens is sometimes the medication is changed and it's not communicated to the GP, or it is not communicated to the hospital, and patients end up having excessive medications, which is really, really disturbing for the patient, because even with annual reviews, the patient is just having a lot of medication just because there was a miscommunication. So choose the medication that has the lowest side effects and not the highest benefit. So stop unnecessary medications. As I told you, stopping any unnecessarily antihypertensive or a statin for a patient. Then consider the impact on quality of life. Sometimes the elderly would just it's more of a mental stress. You would see patients saying that they don't like their life because they are taking 10 medications a day, and they don't feel like themselves anymore. So it's very important to consider the mental impact of these medications as well. So yeah, it's also important that sometimes the patient would just take their evening and morning pills together, especially in case of uh, the dementia patients. So it's really important to assess these patients and give them a proper dosage box and recognize these patients. Okay, so toolkits, as Ollie mentioned, the stop and start screening tools. These are, and there is Beer's criteria. So Beer's criteria is basically identifying the high alert medications and high alert patients, and avoiding these medications, high alert medications in high alert patients. So who would be the high alert patients? Basically, any patients with chronic kidney disease, any patients with dementia, patients having recurrent falls, hypotensive patients, diabetic patients, Parkinson's, very important, and patients who are not eating and drinking well. So this would cause more dehydration and increased effect of medication. Then high alert medication, anticholinergic medications. This would cause all sorts of autonomic dysfunctions like incontinence, postural drops, benzodiazepines. So avoid benzodiazepines in elderly patients. Patients would come and say they can't sleep, but it's more important to uh, counsel them regarding exercising rather than prescribing just medications. Then it's important to give TCA, important to recognize TCAs that are a lot of elderly patients are taking TCAs because they are depressed, but it's very important that TCAs have lots and lots of side effects, especially when combined with benzodiazepines or the medications activities. Warfarin always needs to be assessed with the risks versus benefits. Any blood thinner, basically the elderly patients taking would have had an AF episode of AF like 30 years ago, have been taking some blood thinner from for 30 years. So it's very important, like if this patient is having any recurrent falls, having any uh, environmental causes of falls, which is living alone, it's very important to rationalize the blood thinners as a patient might have just have a fall and have very important. Now, the cardiac medications are always indicated to be assessed, especially the antihypertensives and medications like digoxin. Okay, so our next SPA, an 84-year-old male presents with his son with progressive confusion and forgetfulness. So the son complains that the patient usually wanders off from the house, and this has been going on since the past few months. The patient usually takes alcohol 2 units a week. Patient also had a flu 1 week back, which has resolved now. Son reports that the patient has not opened bowels since the past few days, and is having a reduced appetite as well. So, what is your most likely diagnosis in the poll now? Okay. Okay. So yeah, the correct answer is possible dementia. So why would you think dementia, not any other option? So it could be delirium due to constipation as well, but this has been going on since a long time. It's since the past few months. This is the first time that would tell us this is probably not a delirium. It could have been a delirium secondary to flu, but the flu was just 2 weeks back and has resolved now. But this has been going on for a long time. Then Wernicke's-Korsakoff syndrome. This could be an important differential, but the patient only takes 2 units per week, which is much lower uh, than the advisory. Yeah. Okay. So let's go on dementia. So dementia is used to describe collection of symptoms including decline in memory, reasoning, communication skills, gradual loss of skills to carry out the daily activities. Okay, so symptoms. So first symptom, the patient would start, the patient or the family would start noticing is day-to-day difficulties with memory, recalling recently happened. Then would be concentrating, planning, and organizing activities, making decisions or for them, language difficulties. So the dementia patients often do not understand what you're saying, especially for bilingual would have difficulty on understanding one or the other language. So, for example, walking out of Asda and not remembering where your car is something, but walking out of Asda, not knowing if your car is red, blue, or green is something else, which dementia. So next SPA. So 70-year-old man was seen in memory clinic as an outpatient. His mental state examination, he was noted to have disengaged, noted to be disengaged, boredom, as well as making inappropriate comments to the doctor of sexual nature. Is the single most likely diagnosis here. Okay. Yeah. So the correct answer is temporal dementia, also known as the PICS. So these are the types of dementia. Dementia is an umbrella term which includes Alzheimer's, vascular dementia, mixed dementia, Lewy body dementia. So Alzheimer's is the most common one. It is basically because of an abnormal protein surrounding the brain, which is causing, which causes the dementia. Vascular dementia is second most common, usually associated with a TIA or strokes, and mixed dementia would be picture of a patient having a vascular event and also having a Parkinson's disease, or also having and developing a dementia. Then would be Lewy body dementia. It's basically because of Lewy bodies, more common in patients having Parkinson's or having features like Parkinsonism. And frontotemporal dementia, also known as Pick's disease, as we discussed, is basically because of a tau protein developing inside the nerve cells, and this causes patient inappropriate comments and difficulty in language or emotional responses. So, diagnosis and management. It is very important to recognize that dementia is never diagnosed in a hospital, acute hospital setting. It is diagnosed as an outpatient in a memory clinic. Why is that? Because in acute hospital setting, there are a number of reasons causing the loss of patient's memory, causing confusion. Number one being delirium. A structural imaging should be used to assist the diagnosis of dementia. So uh, you would ideally have a CT scan that would have atrophy or small vascular disease, could point out to vascular dementia. Also, this is very important to rule out any other patient's loss of memory or vision. So, how would you manage? So, cognitive stimulation programs for all types of dementia. For vascular dementia, do not use memantine or any acetylcholine inhibitors, um, because it's basically because in vascular dementia, it's basically more of putting the cause, which is a high blood pressure, cholesterol, or diabetes. And mild cognitive impairment, do not use cholinesterase inhibitors except as a part of just clinical study. So, what would be medications? Cholinesterase inhibitors like Apazil, which is the first line, rivastigmine, galantamine. So, now next we do differences between delirium and how to differentiate these. So, as with delirium, plus dementia is slow. So delirium fluctuates, very important, but dementia is slowly progressive. So delirium lasts for hours, weeks. Dementia would last for months or years, and so the patient would have altered level of consciousness in delirium. But in dementia, the patient is conscious. It's not like a hyperactive delirium where a patient or a mixed delirium where a patient just is flat dead and uh, has no knowledge of what's going on. In dementia, the patient is useless and everything. Attention. So actually, there is inattention in delirium and that with dementia. So patient is agitated, withdrawn, but in dementia, in earliest, there won't be any behavioral difficulties. It would be more of a difficulty. In delirium, the patient would have disorganized thoughts. Sometimes the patient would say, I'm in a jail or you're holding against my will. And then other moment he would say, oh, this is basically how delirium presents, but in the patient would have more of a fixed thoughts, like patient would have a firm and fixed beliefs. Next topic, incontinence. So incontinence is basically involuntary loss of urine, generally in an undesirable and hygienic problem. So what are the causes? So in elderly, especially potential decline in mobility, motivation, manual dexterity, the sensory input. So bladder causes decreased in contractility of bladder muscle losing their tone as people get decreased in bladder capacity, ability to postpone voiding, increased voluntary contraction, and increased post void residue. Another very important cause in males would be prostatic hypertrophy, and urethral causes would be decreased in maximum pressure and length, especially in women. So fluid management, important cause, leading to increased water in just before sleeping would cause incontinence. So how we for the causes? The transient causes is a pneumonic diapers. So delirium, infection, atrophic urethritis or vaginitis, drugs, the pharmaceuticals, logical causes, very important functional causes are also incontinence, excessive urine production because of drinking more water or having a disease, restricted mobility, and stooling. Uh, Next SPA. So I'll open the poll. So an elderly female presents with a complaint of incontinence. Patient complains that during the night and the day occurs randomly without any warning signs. She's not able to do this. She complains that the incontinence is usually a moderate amount and she's embarrassed by the same. What is the what is the type of incontinence this patient? Okay. Correct answer is urge incontinence. Why it's not a mixed incontinence? Very important, because this is not happening with stresses like laughing or coughing. It happens randomly, which is very important to note. And also, she's not able to control this, which is leads towards urge incontinence, and it's a moderate amount. So with stress incontinence, it would be mild amount, a small amount, but this is moderate amount. So this points more towards urge incontinence rather than mixed stress. Okay, so what are the types? Stress incontinence. This is because of pressure on the bladder exceeding the ability of sphincter and causing leakage of small amounts with laughing, coughing, sneezing. And rarely occurs at night because in night the pressure is reduced. And in men, it is very uncommon because it would only occur when there's urethral manipulation, like an operation, surgery, or something. And what are the causes? A relative incompetence. It could be because of incompetence of sphincter. It could be the weakness of pelvic floor muscles. It could be malposition of bladder or urethra. What is urge incontinence? Urge incontinence is basically involuntary loss of urine because of uncontrollable contraction of the bladder, with and without. It could be with, it could be without warning, but stress is always with warning, which means with laughing or coughing or sneezing. And urge incontinence could happen anytime, and losses of variable amounts. So with stress incontinence, it's just a few drops or just a small amount of urine that's incontinent. And with urge incontinence, it's usually more amount. It could be moderate to large amount with no warning time, which causes more of an embarrassment and hygiene problems. So it could be because of the genitourinary changes of aging. It could be irritative or neurological conditions. It could be because of infections, diabetes causing autonomic dysfunction, bladder stones, tumors, strokes, and increased abdominal pressure change. Mixed incontinence would be a combination of both of them. So the patient would have uncontrollable contraction of bladder when laughing or sneezing. This would lead to a large amount of urine being passed and unable to control that. Okay. So how would you treat this? So exercises are number one, or the first line treatment. So you would start with, especially in females, bladder training, Kegel exercises, prompted avoiding, scheduled voiding, very important, biofeedback, and electrical stimulation. This is usually the last resort and usually not used anymore. And pharmacological treatments would be alpha agonist as pseudoephedrine and those tricyclics for stress incontinence especially. So, and there are definitely surgical procedures. And for urgent incontinence, the pharmacological treatments would be serotonin, which is the first line drug, and you would see a lot of patients on this. And this basically reduces the bladder motility and increases the sphincter tone. Next, we go on to frail comprehensive geriatric assessment. So, uh, this frail basically it is not an a consequence of aging. So, 10% more than 65 years of patient are frail, and 42% are pre-fail, and almost half of patients above 85 years of age are frail. Frailty is just not being physically unwell. It's basically a combination of physical, psychological, and social conditions. So, patient would have a patient who is just having a physical or a medical problem, we consider frail, but a patient who is having a problem along with living alone, like social living, or lack of any support, or having a delirium, would definitely become. It's basically all three dimensions: physical, psychological, and social. This is awkward clinical frailty scale, which we usually use to see how the patient are, how much the patient scores on this frailty scale, and then make decisions regarding what should be our uh, of care, or what should be our escalation plan for the patient. So, starting from the bottom, term ill patients would score 9, which means that we have less than 6 months. Very severe, less than 6 months of expectancy, and then very severely frail would be patients who are completely dependent and approaching towards end of life. This the patients are completely need help with all their daily activities, and these are more of the bed bound patients. And severely frail would be completely dependent patients for personal care who need help with bathing, washing, eating, drinking, but not like a bed bound patient, and not at the risk of dying within the next 6 months. Moderately frail would be patients who don't need help with daily activities like bathing, eating, drinking, but would need help with activities like cleaning or going shopping or getting groceries. And mildly frail would be people who are gradually slowing down. They need help with some activities of going out, and but no help with any activities inside the house. So vulnerable would be not a clinical frailty score, which means the patient are not dependent for any help, but would the symptoms limit their activities like going out, drinking, going out, eating out, drinking out. So these are vulnerable patients. So 1, 2, and 3 would be basically very fit patients. You won't see, I mean, it's very rare to see patients with a clinical frailty or score of 1 to 3 above 85 years of age. So management. So mild frail, mild frailty would be the patients who are aging well, but this is limiting their progression. And so important things would be keeping them more active, keeping a healthy weight, having a good lifestyle, not smoking, and explaining them about what is frailty, tackling the psychological and the social issues related with that, and supporting them in self-management. Moderate frailty would require a MDT assessment. So MDT assessment basically means including the OT team, occupational therapy team, physiotherapy team, social services, and the medical, and identify who can give the support to the patients. So we are tackling the social component, and be alert to their patient should be alert of their deterioration, uh, able to ask for help. Severe frailty would be more of a palliative planning. This would be all based on making the patient more comfortable rather than any prognosis. So medical component for frailty would be cognitive assessments and basically disease-based guidelines, tackling any medical conditions, medication review as we have talked multiple times, polypharmacy, and identifying any small medical problems uh, like a hearing problem and optimizing them. So each patient needs a individual plan, and it's not like a generalized plan because each person's medical, psychological, and social conditions are different. So these should be based on the patient's goals and what are the patient's own preferences and what is the expectations that we and the patients are expecting. And we should anticipate the patients, especially the patients who are going from mild frailty to moderate or moderate to severe. It's very important to anticipate them and provide with them with the enhanced care before they land up into getting more frail. Okay, the next SPA. So there's an elderly gentleman who is admitted the hospital as the wife is not able to cope. Your registrar on the frailty team asks you to assess the patient and scale the patient according to Rockwood clinical frailty score. So the collateral from wife. Patient is usually confused, not oriented to time, place, or person, has a background of dementia, hypertension, type 2 diabetes. Wife and the daughter usually bathe and dresses the patient. Patient has once a day package of cares, has carers coming in once a day, but otherwise the patient is medically well, no respiratory or urinary symptoms. What would be the patient's clinical frailty score on the poll? Okay, so the correct answer is C, which is 7. Why it's not 8? Because the patient is not bed bound. Why it's not 6? Because the patient needs help with bathing and dressing. And definitely this is not 5, as the patient is needing help with the daily activities. Okay, so what is comprehensive geriatric assessment? So this is uh, the gold standard for assessment in and management of frailty in older people. So this is important for all the people who are recognized to have frailty, basically score of 7 or above. So this is includes interdisciplinary diagnostic and therapeutic process, which means that it needs to be multidisciplinary team, which includes the physiotherapist, OT team, social services, and the medical team. And important to uh, identify and tackle all the components of frailty, which is medical, social, psychological, and functional needs. So, and development of an integrated plan for this. So, what are the domains? So, first is the medical, and second is the functional domain. So, medical would be basically the managing the comorbidities, uh, managing polypharmacy, weight, nutrition, incontinence, vision and hearing, and advanced care planning for future. Whereas functional would be more of our physiotherapy and occupational therapy colleagues, which would be managing the gait and balance, falls assessment, transfer and mobility, helping with the personal ADLS and instrumental ADLS and advanced ADLS. So the others would be psychological domains, looking after the mood and cognition and tackling the ICE, which is ideas, concerns, and expectations. Social and environmental would be organizing a package of care, which basically means organizing carers, making sure the home is safe, hazard protection, and yeah, preventing social isolation and loneliness, and accessibility to local resources and financial assistance as well. So, what are the social circumstances that need to be considered? So, right from these need to be considered right from the first presentation. So, when you take a history from any elderly patient, it's important to see what package of care they have. Basically, meaning how many times a day they have carers coming in, who is the main carer, who are the family members who live around, and where do they live? Not around, where do they live? How accessible are they to the patient? And what's the living situation? Is it a house or a flat? it, if it's a flat, is it a ground floor flat, or does it is it a first floor or second floor flat? Does it have a lift or stairs? Same with the house. Is the bedroom on ground floor or the first floor? And the stair assessment. So what's rehab and MDT? So basically, after hospitalization, 11% of the people are referred to rehabilitation facilities. These are basically the rehab centers, and this basically increases the disability related to musculoskeletal disorders and depression, diabetes, neurological conditions affecting mobility and activities in particular. So this should emphasize on functional activity to maintain functional mobility and capability, improvement of balance, and through exercise and functional activity like weight shifting exercises. This would help patient gain muscular mass and also become more confident. So ambulation with direction and elevation changes, and good nutrition, which is very important. So the patients who go home without rehab would end up having a readmission just because they are not eating and drinking. So rehab helps us with this. So this reduces the hospital stay and helps the patient to get additional support to get back to his own self and get back to his baseline. And also the patients with rehab have more of a social and emotional support as well. So this is basically under 7 principle, totality of the patient, which means we should consider all the aspects: medical, psychological, psychosocial, and individualization, which means tailored to according to the patient. Intensity, which means it shouldn't be too intense. It shouldn't be like a bedbound patient who is getting better, who was bedbound for a week or so, getting better and starts running. It should be less intense for this patient and more intense for a patient who was completely independent previously. So specific sequence. So this means that it shouldn't be like uh, just running before walking. It should be in a specific gradual manner and in a sequenced manner. And then it would be compliance. If the patient is compliant, nothing should be forced as it won't work. And then timing, how long and how frequent we are doing, and avoiding any aggravation. So next topic is the multidisciplinary team. So it is the team with specialized knowledge and skills dealing with elderly people. And who are the what compromises the MDT team? It includes the medical team, OT team, physiotherapy team, community nursing team, complex discharge team, social services, and rehab assessment team. So these all play a role at different levels, right from the admission by multidisciplinary team, and then discharge planning by the occupational therapy team, rehab by the physiotherapy team and rehab assessment team. Then in community nursing, and when the patient goes back to home, community nursing team comes into play, and social services come into play, and complex discharge team obviously when the patient is having multiple psychosocial issues to be dealt with before the discharge. That's it. Thank you, guys. I am sorry the session went a bit long, and that's it. If you have any questions, then go for it.